Welcome. We are happy to have all of you here again today for, as I mentioned, this is our bi-monthly Jim Pettison Lunchtime Learning Session. Today we are showcasing the Chronic Pain Clinic. We're really excited to bring this information for you today. Just before we get started straight out of the gate, I do want to do a bit of a territory acknowledgement and acknowledge the land that we are joining in from today. So my name is April. I'm calling in from the Surrey-North Delta Division of Family Practice. We're at our head office, our main office. Sorry, and I want to acknowledge with a deep sense of respect and gratitude that our conversations today are being held on the ancestral and traditional territory of the Coast Salish people. And so for us, that means the Kwantlen, Semiahmoo, Tawasin, Katzie, Coquitlam, Quayakut, and numerous Dolo First Nations. And because I am calling from the Surrey North Delta head office, very close to us is Tynehead Park. And so we often will gather together as a team and go for walks at Tynehead. And it's a really nice opportunity to reflect on the land that we are graciously sharing with our First Nations community partners. As we move through, you'll notice that there'll be some housekeeping that are sort of standard ways we do our Zoom calls. If you haven't turned on your camera, we invite you to do so. We love to see all of your faces, but we do ask that you keep yourself muted when you're not speaking. There will be an opportunity at the end for you guys to ask some questions for the Jim Pettison team. So please use the chat function if you have some questions as they're going through their presentation. And then at the very end, you can use your raise hand option if you want to chat directly. There will be an evaluation link at the bottom at the very end, so please stay tuned for that. This is a quick 30-minute discussion this afternoon, and your CME credits will be sent out to you after you've done your evaluation form. So without further ado, I want to introduce the pain clinic. We're joined today by Lori Chiesa and Janet Reynolds. Lori is the Clinical Operations and Program Services Manager, and Janet is the Patient Care Coordinator. And we're really happy and excited to have them with us today. So Lori, Janet, over to you. Welcome. Thank you so much for being here.
Thank you, April. Hi, everyone.
Hello. Thanks, everyone, for joining Janet and I today. Hoping I had met some of you at our open house that we had, I think it was a few months ago. But for those who haven't, my name is Lori. I'm the Clinical Operations Manager for the Chronic Pain Clinic, and Janet is our Patient Care Coordinator. She's probably the first person you would touch base with if you had any challenges and needed some help within the clinic. I cannot see anybody's face in this presentation, just so, so Janet or April, I'll need you to stop me if I need to stop, but okay, let's move on to the next slide. So just some of the objectives of this presentation today. We are going to do a service overview of our clinic, as well as a quick definition and types of chronic pain, how to make a referral to our clinic, some of the common mistakes to avoid that may delay the patients getting started to be triaged and processed through our clinic. Then we'll also do a brief overview of the triage process, our education classes that we offer, a little overview of the journey, the patient journey through our clinic, and then just a bit of our updates on new initiatives, and then of course our contact information and location. So just a quick overview of our service mandate and our mission statement. So the chronic pain does exist to provide timely and comprehensive pain management to improve quality of life for people and their families living with chronic pain and Fraser Health. We also use an interdisciplinary approach to provide time-limited consultation, so not long-term, but time-limited consultation and follow-up on chronic pain management using a combination of self-management education, individual and small group therapy lessons, and as well as interventional techniques for pain management. Self-management education does focus on increasing quality of life and decreasing pain through exercise, lifestyle changes, mood management, relaxation techniques, and mindfulness strategies. And you'll note I mentioned to decrease pain, not necessarily eliminate pain, because that's a bit of a, we'll talk more about chronic pain that Janet will go into.
Thanks, Lori. So many of you know chronic pain is a long-standing pain. It persists beyond the usual recovery period. It can develop without a known cause or may develop after an injury has happened. It can also develop after a condition has been treated. And it can be influenced by biology, psychology, spiritual factors, as well as emotional factors. We have many types of chronic pain that can exist. Some of the conditions most commonly seen within the chronic pain clinic do include arthritis and joint pain, back or neck pain. We do see a lot of lumbar pain, muscle pain, headaches, including migraines, nerve pain, as well as complex regional pain syndrome, and things like fibromyalgia, chronic widespread pain, and we do occasionally see cancer pain as well. So making a chronic pain clinic referral, saving the link rather than a blank referral form on the desktop will ensure the most up-to-date form is utilized and will help to reduce delays in processing the referral. We have changed our referral a couple of times over the last year. So referral and intake forms can be found on the Fraser Health medical staff website. There's the link on the slide there. They're also available on Pathways. You would enter a chronic pain clinic in the search bar and then select the chronic pain clinic referral and chronic pain intake. The intake forms used to be quite long. They're now only 2 pages. As you can see there on the left, we have our referral forms, which the provider would fill out, and the intake forms would be for the patient to fill out. So all referrals must include a referral form, the intake forms, and relevant consultations and imaging reports to actually be considered complete. We do get quite a few incomplete referrals. Please note again, these are updated forms, particularly the intake form, which has actually decreased from 12 pages to 2, so much less to fill out. And please also note the specific inclusion-exclusion criteria outlined on the referral form. I'm going to cover that. Specifically, we do not provide opioid prescriptions here within our clinic. To ensure that the referrals are processed efficiently and your patients are seen as soon as possible, some of the most common mistakes we see with referrals include missing or incomplete intake forms. So those are the forms that were on the previous slide. They do need to be complete for us to triage the patient. Missing or incomplete referral forms, and as well as a lack of clarity regarding the reason for referral. So what is the question you would like to have answered by our pain team here in the clinic? Sometimes we will have multiple complaints on one referral. We prefer to just have one. What would the priority be? And then most often I would say is missing imaging reports and or applicable consults. So CTs, MRIs, X-rays, any specific consultations. So we do, for interventional requests, we do require a recent MRI or CT. Please note we cannot do those faster here. They do need to be done prior to coming here. Let me just, Lori, I think the next one is you.
Sorry, I muted myself and I was talking.
That's okay.
What happens when we do this over lunch hour. All right, so just a brief overview of our triage process. So all referrals that are submitted to the chronic pain clinic follow the same triage process. So the form comes in, it's reviewed as complete or incomplete. If it's complete, then the RN will review the package. So in consultation with the pain specialist, the RN determines whether referral is deemed routine or urgent. So what that means is the RN is looking for important factors, making sure all records are showing a resistance to conventional treatment and other relevant specialist report. An example of a referral needing pain specialist consultation during triage would be if a specific intervention is requested by a specialist related to a diagnosis or pending surgery. So that would be considered a bit more of urgent with consultation with our specialists here. Excuse me. Just, I know everybody's going to ask me what the wait times are, especially when we say our mandate is timely access. And of course, with the volumes coming in, we've been looking at processes to streamline that process, one of them being the intake forms being 2 pages and trying to simplify the referral form. But our wait times right now are approximately around 7 to 9 months. However, knowing that this can change depending on multiple factors. For example, we do have a couple of new physicians on our team, on our medical team, and so they are taking more new intakes as they build their panel size. So our our wait times will drop a little bit, but then with the volumes coming in, we expect they will stay around an average 7 to 9 months. And that's really important to pass that on to patients so that they're aware that it's, it is around a 7 to 9 month wait. All right, Janet.
Okay, so we do have a wonderful team here within the clinic. Lori will discuss a little bit about the journey through the clinic, but we do provide educational classes for patients within our clinic. One of those is from our pharmacy team. They do a class on chronic pain and medications where participants learn about the different types of pain, as well as various pain medication options. We have our wonderful physiotherapist, our occupational therapist doing an introduction to mindfulness class. This teaches the benefits of mindfulness and how it can improve mood, brain health, sleep, and physical well-being. And our physiotherapist teaches a gentle movement and relaxation class. These are done virtually. All of the classes are done virtually. This teaches gentle movement and that it is safe for everyone, and it can help patients connect with their bodies in ways that do not exacerbate their pain. Our sleep class is led by our psychologist and focuses on mindfulness and relaxation for better sleep hygiene. Lori?
All right. So the patient journey through our clinic. So our referrals come through via fax, as you know, and we have gone to paperless right now. So that's a process we just started at the beginning of April. So the complete referrals are reviewed and triaged by the RN, as we mentioned before, as urgent routine or appropriate for self-management classes. So the self-management classes are the community pain self-management classes they're connected to JPOC, but they're, outside of it in the community. Any urgent and routine referrals. So appointments are then booked with a medical team. And so sorry, I'm reading my notes and they don't make sense to me. So what happens is they are first initially booked with a medical team. We used to have it where there was a couple of streams. There was 3 in total where it used to be self-management, allied health, or the medical team, but we found that most patients really did want to see a medical team member. So we streamlined that so they were seeing the medical team first. And then the patient will be contacted by our clerks, given their initial appointment. And we also use the My Fraser Health Visit app, which does reminders via email as well as text. And then the patient will attend the appointment with the medical team. And at that point, they will go through what's needed, the medical team will decide which is the best way. Do you go for a procedure? Is it going to be self-management classes? Or will they book you in or maybe the multiple of all, or the allied health as well. So our physio or OT or our psychologist. We do also have a psychiatrist that works a very small FTE in our clinic that can be utilized as well. Then the patient is again booked for their procedure or allied health appointment. And then once they've finished their limited number of appointments, and we don't have a number for each appointment, like how many times you can see the physicians or the NPs, or how many times to see our allied health. It really depends on the clinical judgment and the need of the patient. But again, it is time limited. And then what will happen is a summary of care will be sent to the referring provider with what happened and what the recommendations are from the perspective of the chronic pain clinic. And then the patient will be discharged from our clinic. We're going to tell you referrals that appear unusual will be reviewed by our patient care coordinator. So if they're a bit more unusual or complex, then Janet will be reviewing them and discussing with our medical team. And if it's an incomplete referral, what will happen with that is it'll result in a fax letter to the referring physician's office, which will also include the new version of the referral and intake forms. The incomplete referral will then be shredded and a new referral package will need to be submitted. So I understand that it's a lot of work to have to repeat that, which is why it's really important why we want to do this, these lunch and learns is to really clarify the process and the paperwork. And we simplified the paperwork because we do not have the capacity to keep the incomplete forms and then try and match them up because we get about 40 referrals a day. So it's not possible for us. So when we send for an incomplete, we will need those documents filled again.
Okay, so we are establishing a couple of new roles within our clinic, one of those being the patient navigator role. This is a new RN role to streamline the referral process as well as reduce wait times. Sorry. The RN will conduct a pre-appointment telephone interview using an SBAR, so situation, background, assessment, recommendation framework, as well as a medication review with the best possible medication history. These assessments are included with the referral form for the medical team to review prior to meeting the patient for the first time. The chronic pain clinic team has begun placing RN referrals to ensure patients receive follow-up and move through the clinic appropriately. We are working to front load patients on the wait list with as much education as possible before their first visit, as there is, like Lori said, the 7 to 9 month wait. And then we are looking at doing a pathway for widespread pain as well, for example, fibromyalgia. This is under development. So our team, along with our community program, are creating a class specific to chronic widespread pain disorders. It will be a guiding pathway through the clinic, and our goal is to develop this pathway within the clinic and eventually transition it into the community. So here's our contact information. We are located on the 3rd floor of the Jim Pattison Outpatient Care and Surgery Center. We're here Monday to Friday, 8 to 4. And I do believe that is it for us. So thank you very much for being here today and listening to our presentation.
Thank you so much, Lori and Janet. I'm going to open it up to the attendees to see if anyone has questions. There aren't any in the chat just yet, but if you have something that you wanted to ask Lori or Janet, please either raise your hand or just pop it directly into the chat and give a minute here. For those of you who don't have questions, Gurveen has put the evaluation link into the chat as well, so please go ahead and begin filling that out. And I do see Dr. Saroj Kumar's hand is up. So Dr. Kumar, please go right ahead.
Hi.
Hi, Dr. Kumar.
The definition of the chronic pain is more than 3 months, I understand. And the wait time is 7 to 9 months. So that is almost a year already. And that is grave, very grave, that pain has to be to that extreme that it waits for 1 year to get assessed. Number one. Number two, you just mentioned that you get about 40 referral a day. And my question would be, how many patients actually you can see or triage in a day?
All right. No, thanks, Dr. Kumar. Agree. 7 to 9 months is a long time when they've already been suffering for at least 3 months, because we all know that once they're diagnosed as 3 months, falling within that scope of 3 months of chronic pain, they've already been dealing with the pain longer than that. It's the sad thing is we're one of the lowest wait times right now. But from a regional perspective and a provincial perspective, I want to let everybody know that it is being looked at, the long wait times and the access to tertiary care and multidisciplinary groups, and that there is likely a better way to navigate patients through their chronic pain. And it's not just sending them all to the tertiary sites like Jim Pattison's Chronic Pain Clinic, right? There is the majority of chronic pain can be looked at through self-management and patient education. And there's so many resources out there that I think people aren't aware of, that we're trying to, bring it all together. And is there a way that primary care and Pain Care BC we can all work together, and Pain BC to work together to, instead of us all doing the same thing, that we can look at what areas are doing what and refer patients there for the education, so that by the time it's almost like it's not a tier system. Can't think of the word, but
Step care.
Thank you. Step care. A stepped care is like someone is coming in 3 months now, they're now diagnosed with chronic pain. Okay, the first step is here's some self-management classes you can start with, as well as putting your referral in, so that there'll be care that can be given, or there's things that the patient can be doing before they actually be seen in the clinic, which would be much more effective for when they come to see us. When they do see us in 7 to 9 months, then there's some patients that don't even need to come see us. So that again would reduce the volume coming in, because they'll realize that self-management is all they'll need. And then that leaves more space for those more complex pain patients that do require interventional treatment or multidisciplinary care. Because I don't think everybody needs multidisciplinary care. I think that that's sort of where we're going with our stream around the widespread chronic pain, is trying to streamline it, bring people together in like a cohort to do the education that way, and still see the medical team and still be available to see to have interventional procedures done, but not, it is just taking them faster and getting them through and giving them the education they need, because patient education is really the biggest thing. Research, I just went to the Pacific Pain Forum, and research is showing that interventional treatments are actually not that effective in chronic pain. It's self-management. And what was the second part of that, Dr. Kumar?
I think how many people we see.
You mentioned that you get about 40 patients. So how many patients can you triage a day?
Yeah. Well,
no, I'm afraid of the bottleneck. That's what I'm talking.
Absolutely. And that is something we are struggling with, is that bottleneck. And I mean, Janet she does triaging with we have one RN, and Janet is our PCC. So the one RN is technically the one doing the triaging, and Janet will assist when she can as well. I am looking, because of the patient navigator role, which will be part of that and includes the triage, I am trying to see if I can get some more RN dollars. A little difficult right now with just, new fiscal year, new government and stuff. So, but my bigger vision would be, we need more RNs in our clinic to provide that patient navigation and triaging. So Janet, you and Jamila are RN, we're doing some triaging. How much would you say on average you could do in a day?
I would say we can probably do 15 to 20 a day. Again, some of those are either denied or incomplete. Again, that's why we really focus on having a complete referral, because if they have waited 3 or 4 weeks to be triaged, and then we have to send it back, maybe to get some imaging, or then it's another delay by the time it gets back to us for triaging. Within the clinic, I would think, I don't know, Lori might be able to answer that. I'd say probably 20 to 30 patients are seen a day. Would you agree, Lori?
Mm-hmm. Sometimes more. And then our procedures are, they're seeing about, 15.
Yeah. And again, with the patient navigator role, we're really hoping that will help streamline our process a little bit and make the appointments move a little bit faster, because the pain team will have that will have that information ahead of time. So it will hopefully make things go a little bit faster.
And with the Surrey initiatives that happened earlier, mid last year, we were able to expand. We did get more physio time. We have dollars. We had a second NP brought in, which is fabulous. We want to bring in more NPs into our clinic because they're a great addition, especially with chronic pain. So we have a new NP. We'd like to hire a third. And what else we got? We got a physio. We got another psychologist that we're still trying to recruit. So we're kind of, the difficulty is sometimes hiring into those positions, of course. And psychology, physio, NP. I think that was what our dollars were for. So yes, we did get some expansion there. And again, my hope and dreams is I can get some more RNs as well. Our medical team is a great team. We have 13 medical team members. And as I said, a multitude of anesthesiologists, physiatrists, and NPs.
Thanks, Janet. Dr. Kumar, thank you so much for the great question. There are two additional.
I just have another small question.
Sure.
Do we have access to the patient educators? So we could bypass the pain clinic and refer directly to the patient educator, because it does play very, very important role.
Absolutely. We have there's the community pain self-management program, and you can refer to them, and they get in the community self-management program. What they do is we have another patient navigator, and they connect with the patient. They explain that it's an 8-week class that goes over multiple different parts of chronic pain, as well as how to manage it. So incorporates a lot of the things our clinic and our specialty classes are, but just a little more, just on a more general sense. And, but yeah, it's an 8-week, they get a 1-to-1 with the RN or the other clinicians. They have access to an OT, a PT, and RN. And that is also part of our program as well. So there is a referral. We could include that. You can share that referral with the team. I believe it's on Pathways as well. It should be on Pathways.
What I meant is bypassing Jim Pattison Pain Clinic referral and
Yep.
just send directly to the self-management clinic.
Yeah, that's all sent. We can send you the referral for that. Yeah, it's completely separate.
Thank you.
No problem.
Thanks, Dr. Kumar.
There's 2 additional questions in the chat as well. The first one comes from the group at Sullivan Medical, and they just want to confirm that incomplete referrals will not be kept and need to be resubmitted with the correct information. Is that correct?
Yes, that's correct.
Okay, perfect. And then Dr. Nisha Abraham has a really great question in the chat. Is there a way we can get some advice from the pain clinic while we're waiting for an appointment so we can try and help in managing the patient's pain in the meantime?
That was around that rapid access, isn't it? And we don't have a formal here for rapid access. I believe there is. Can I get back to you on that? Because I believe there is a rapid access for consultation. It's not connected to JP, but it's around pain. It's escaping my mind right now. So I'll come back to that. I'll bring that back to April. I can bring that information. And, I'm really hoping that shared care, we have a chronic pain shared care proposal we put in that is around providing education and resources to the division, to all the physicians within the division on these resources to make it more clear, more simple for everyone, quicker, efficient. Is that the word I'm looking for? To finding these resources and some more clear pathways, the same for the self-management. And so fingers crossed, as well as patients, we'll give more information and guidelines for patient care as well. So there's fingers crossed that we'll get approved for that, right, April?
You're sending out some good vibes for that. And Dr. Abraham, just to that point, we know that there's a bit of a gap in the community right now. We want to help support family physicians whose patients are waiting to be seen. And so while Lori has provided some information and like she said, is going to provide us a little bit more, which we can send out to the group as a post-session resource, we are very confident that we're going to get a little bit of funding from ShareCare to help create some things to help support you as a family doc who has patients waiting to be seen. So that's the goal for that project. So fingers crossed for that.
Yeah, and absolutely, there's always, you have our contact information. You can ask to talk to Janet as our PCC. Janet's not there. You can ask to talk to myself as well. I have no problems with that if you're needing some support with that. Or if you want to follow up. I know sometimes the biggest complaint people say it's really hard to get a hold of, within the pain clinic. We have worked to improve our telephone tree. So, but happy we have the contact information there if you need us.
And there aren't any other questions. Dr. Abraham says, thank you. That would be great if more resources open up, and we agree, it will be great. Any other questions if anyone wants to put their hand up?
And while waiting, I think there is lots of, like I said, I'm in multiple groups around pain that are looking at streamlining and making it simpler for the patient journey. And so, it's coming. It is coming. The bottlenecks, the delays, and the struggles with the patients and the, referring clinicians, the challenges they have are being recognized, and we need to improve that. So, and Jim Pattison being the only multidisciplinary pain clinic within Fraser Health does make it challenging. So that's where we're relying on our other partners to assist with that. So we'll get there.
So, without any additional, go ahead. I think somebody was about to say something.
Question for April.
Oh, sure.
It's a bi-monthly, right?
That's correct. Yes.
So, okay, thanks.
Yeah. Our next session will be in June, and I can't remember off the top of my head who we have in June. Graveen, do you happen to remember?
I can quickly look it up here.
And while we're just waiting here for a quick second. If you have not yet filled out the evaluation for this session, please go ahead and do so. It has been posted in the chat. Glad to have seen all of you guys with us today. Again, our next session for these will be in June. And I want to give some thanks to Janet and Laurie for putting together a great presentation and answering everybody's questions. The resources that we mentioned are going to be sent around along with this slide deck, so you can look for that in about a week or so. And the session today has been recorded and will be posted on the Surrey-North Delta YouTube channel. If you haven't subscribed to that, please go ahead and do so. You can just look us up on YouTube. There's a lot of great additional resources there from this session as well as from our previous Lunch and Learn.
We'd like to go viral, please.
Yeah, right, exactly. Our next session in June will be with the Diabetes and Pregnancy Clinic. So we don't have a date yet, but just hang tight for that. Information will be sent out in the coming months. It is 1 o'clock, so thank you for joining us today. We hope you have a fantastic rest of your afternoon, and thanks for being here.
Thanks, April.
Everyone.
Thanks.